All right. So she says I'm live, so that means it's time to go. So I'm Dr. Jeff Postma. I'm going to talk to you about my aching shoulder. Probably not my personal aching shoulder, but at least some of the common problems and treatments with shoulder problems. And so I'm going to kind of run through a whole gamut of things, and then I'll have some time for some questions and answers afterwards. So Lakeland has a number of operating orthopedic surgeons. So my background is I'm a native of Michigan. I'm originally from Holland, Michigan. I went to Holland High School. I went to Michigan State, and I went to Michigan State for 14 years. I always tell people I couldn't get it right the first time. So I did my undergrad there, I went to medical school there, and then my residency was with Genesis in Flint, which is also associated with Michigan State University. My orthopedic career, I started practicing orthopedics in 1997. Originally started in South Haven. I moved to Watervliet and have been here for the past 6 years. And I operate out of this hospital here, and our office is in Coloma at Community Bone and Joint. So, giving you a little preview about the topics that I'm going to try to cover tonight is I'm going to talk a little bit about basic shoulder anatomy. I'm going to talk about what shoulder pain is, the different types of shoulder pain, the causes, some of the signs and symptoms, and then, of course, hoping to talk to you about the treatment. So shoulder pain, and when we look at shoulder pain, the common things that are kind of thrown out is impingement syndrome, bursitis, rotator cuff tears, biceps tendonitis, and shoulder arthritis. That's kind of the big categories, and you'll hear people talk about their impingement syndrome and rotator cuff frequently. So talking a little bit about the anatomy of the shoulder, and if I kind of go through a little bit of anatomy, it kind of helps to understand where pain comes from in the shoulder. So when we look at the bones, we have the scapula, that's your shoulder blade. The shoulder blade has this portion of it right here called the glenoid, that's the socket. Running off the top of the shoulder blade is the acromion. That's this bone that you feel right at the top. Right at the top of your shoulder is the acromion, and then attached to it is your collarbone. That's the clavicle. And then we have the humerus. That's your arm bone. The arm bone has a ball on the top. That ball fits into the socket, which is the glenoid. The muscles of the shoulder, the primary muscles of the shoulder are your rotator cuff muscles. And we look at all those muscles kind of attach right to the shoulder blade. So when we look at the front of the shoulder blade, we have the muscle right here called the subscapularis. So the front of the shoulder blade is really what, when you feel it's the underneath side of it. That subscapularis runs across the front of the shoulder. And then the muscle right above that is the supraspinatus. Supraspinatus is kind of unique in that it's one of the only muscles in our body that lays between two bones. So it's right underneath the acromion and right on the top of the ball. And then across the back of it are the muscles, the infraspinatus, and then this muscle right here, the teres minor. So that's the four big muscles of the rotator cuff. The other big muscle we have to know about is the deltoid. So whenever we raise our arm up, we see this muscle that lays right on the side of the arm. That's your deltoid muscle. That's one of the major muscles that help us with motion of the shoulder. And then we look at the bursa of the shoulder. And what's a bursa? A bursa is just a potential space. We have a bursa that lays on the back of our elbow, helps the bone glide over top of the skin. You have a bursa over top of your kneecap that lets the skin glide over top of that bone. In the shoulder, there's, hit the right one here. There's a couple different bursas inside the shoulder. Kind of the big one is the bursa that lays underneath the acromion. It lays between that bone and the rotator cuff muscle. So it lets that rotator cuff muscle glide back and forth. Now I also want to point out some ligaments. We have a ligament that runs between the collarbone and the acromion, and then across the front between the acromion and the coracoid. And then there's a couple ligaments that make up part of the capsule of the shoulder. So the shoulder joint is kind of a joint that sits inside of a balloon. And that balloon is made up out of those ligaments. When we start talking about problems to the shoulder, impingement syndrome. And an impingement syndrome is just that. It's a syndrome. It's a series of things that happen. And it starts out as a bursitis to the shoulder. That bursitis leads to a rotator cuff tendonitis. So just an inflammation of the rotator cuff, which proceeds to a rotator cuff tear or a rotator cuff tendinopathy. So some changes to it. And then a rotator cuff arthropathy, an arthritis to the whole shoulder joint. So with impingement syndrome, keep hitting that wrong one. We have the ball, the socket, you have the rotator cuff muscle, the supraspinatus, and we have this bursa that lays between that helps that muscle glide. Well, if we develop what we call a spur or an arthritis of the acromioclavicular joint, and you have this little downsloping, it pinches the rotator cuff. And that's what's kind of demonstrated here is that rotator cuff muscle getting pinched between the bone above and the bone underneath. So impingement syndrome is an inflammation of the rotator cuff and the rotator cuff bursa. It's a mechanical impingement, something that actually pinches that muscle. It leads to pain and it leads to weakness. Because the rotator cuff helps us in elevating our arm up, it makes it difficult, makes it weak to raise our arm up. And as you bring your arm up and over, it increases the pinching and causes pain. So any type of overhead work. I tell my wife that's why I can't wash windows around the house, because I can't work with my arms up overhead because I'll get impingement syndrome. And then you wind up getting that weakness to the arm. So when I explained impingement syndrome to people, I like to try to keep things in pretty simple terms. And so that's what these series of pictures kind of demonstrate. This is a piece of paper and it has a pencil mark on it. The pencil mark is bursitis. So you can get rid of that bursitis and we can take an eraser and you erase it. Well, even when you erase it, you can't completely get rid of that pencil mark. So bursitis can kind of come and go. Doing the overhead activities, going around the house, washing windows and getting sore shoulder. That's kind of that recurrent bursitis. Well, if you keep erasing in the same spot, that paper starts to roll, starts to pill. It kind of gets that funny texture to it. We call that tendinopathy, and that's where you have changes to the rotator cuff tendon. Well, if I keep going in the same spot over and over, well, I create a hole in the paper. That hole in the paper is a degenerative tear of the rotator cuff. So it's a degenerative rotator cuff tear. Well, if I keep erasing in the same spot over and over, then what happens is I wind up messing up the table underneath. Then it develops into an arthritis of the shoulder. So that's the whole series of things that occur. Like I said, we start out with a bursitis. That's that inflammation, the inflammation of the bursa, inflammation of that muscle. It's due to that mechanical impingement. It can be due to an injury. If you fall, land on your shoulder, you can create a bursitis to the shoulder and make it difficult to raise your arm up and have that weakness to it. So what do we do with impingement syndrome? I look at all my treatments as kind of a pyramid. We start with the basic things. We start with conservative things. Tell people you can rest. You can use anti-inflammatories. That's what NSAIDs are. They're Motrin, ibuprofen. Above that, cortisone injections. We do a cortisone injection into that bursa. It helps to decrease the inflammation, and it can be curative. And then above that, physical therapy. One of the primary muscles of the rotator cuff is the supraspinatus. It helps us in raising our arm up. It is the one that lays between. So if we strengthen the other three muscles of the rotator cuff, it pulls the ball down into the socket and can help to alleviate symptoms of impingement. So that's where physical therapy is quite important. When we talk about conservative treatment, we know that 50 to 90% of the time, conservative treatment is effective to taking care of the shoulder pain of impingement syndrome. Kind of the unfavorable things is that if you have a rotator cuff tear that's greater than 1 centimeter, the conservative treatment probably isn't going to give you a complete relief. Or if you have symptoms greater than 1 year, or if there's a functional impairment to the shoulder. Functional impairment meaning that you can't lift it, it just doesn't work. Then the conservative treatment probably isn't going to be effective. So 86% of the people that are treated conservatively have satisfactory results. That's if the symptoms are within 3 months of starting conservative treatment. So as soon as you have shoulder pain, if it's treated conservatively, you have a pretty good chance of alleviating the symptoms. After 6 months, it's only 56% positive. So, the longer you have shoulder pain that goes untreated, the less effective some of the conservative treatment can be. After we do conservative treatment, then we start looking at surgical treatment. Our surgical treatment is when we start looking at getting an MRI of the shoulder. The MRIs can look at the rotator cuff muscle. Where's my pointer? It looks at this rotator cuff muscle. It looks at the bursa, this dark spot, to find out if it's ready for a surgical treatment of the shoulder. It helps me with my surgical plan. So what's the treatment when I look at surgical treatment of impingement syndrome? The first we look at is this acromion. Sometimes that acromion has a little bit of a curve to it. We call that a spur. That spur makes it prone to developing impingement. So we decompress the shoulder. We take that spur and remove it. I have a little burr. It's kind of like a little Dremel tool that we use in surgery, and it actually cuts that spur off to make more room for the rotator cuff. That's done with an arthroscopy. So that's where we just make a couple poke holes on the shoulder, go inside with a camera, and do that decompression. Sometimes you have arthritis at that acromioclavicular joint where the collarbone is, and we actually remove the end of the collarbone to alleviate symptoms. Like I said, the next stage of impingement syndrome is rotator cuff tears. So we kind of put that part of impingement syndrome, but it really needs a subject all by itself because everybody hears about rotator cuff injury and rotator cuff tears. So a rotator cuff tear can be 2 different types. It can be a degenerative type tear. That's what I described with paper and kind of that constant rubbing and creating a hole. Or it can be acute tear, falling on an arm, having your arm out and getting your arm jerked. It can actually cause that rotator cuff to be pulled right off the bone. So rotator cuff tears are extremely common. When we look at how common a rotator cuff tear is that people who are 65 and older, about 50% of those people have a rotator cuff tear. As we get older, it becomes more common. So when you hit 80, there's about 80% of the people that are over 80 have a rotator cuff tear. Those are degenerative type tears. Most of those are asymptomatic. So people don't really have any symptoms with them. They continue to function, continue to move their arm, maybe having some pain with reaching up. And it's not until they do something different that causes them to be symptomatic. So 30% of the tears develop pain after 2 to 5 years. So, and that's with doing some type of activity that causes that pain. So when we look at tears, now we can say there's two different types of tears. There's partial thickness tears or complete tears. When we look at partial thickness tears, that's where you start to get that scraping of that rotator cuff, that pencil mark that starts to roll that paper and thin that paper. And then we can have complete tears. That's where there's a full tear to it. When we look at an MRI, this is the rotator cuff muscle, the supraspinatus. It comes and it attaches on that humeral head. If somebody were to fall and have a complete tear, this is the supraspinatus, this is the tendon, and it should be attached down here. So that's a complete tear of the rotator cuff. So causes of the rotator cuff. Like I said, there's a couple different shapes of this bone, the acromion. People can have what we call a type 1, it's flat. A type 2 has a little bit of curvature to it. And a type 3 has a hook on it. That's what we kind of call that spur. People who have a type 3 acromion, the majority of those people will have some type of problem with their shoulder at some point of their life. When you have a type 2 acromion, it certainly makes you more prone to having it. When I talked about removing that spur, shaving that spur off, we take something that's a type 3 and a type 2 acromion and turn it into a type 1. So there's more space between that ball and the rotator cuff. So a rotator cuff tear. Most of the time, it's of the supraspinatus. That's that muscle that lays between the two bones. It can get torn right at its attachment. Rotator cuff tears can be small or they can be large. So some of them are relatively more of a pinpoint, and some people have tears that are up to 2.5 centimeters, so up to an inch in width. Rotator cuff tears generally don't heal on their own because you have joint fluid that's inside this joint here, and that joint fluid comes out between the tear and never allows that to reattach. Also, you have the ball and that rotator cuff muscle. That muscle is what contracts to move the arm. If it's torn, it's all of a sudden it's pulled out here, so it never heals back to where it was because it doesn't rest there. It's resting away from its position of where it should be attached. So the treatment for rotator cuff tears, if they're degenerative type tears, so the chronic ones that a lot of people have, we can do observation. We do the conservative treatment. We have just let there be a little bit of rest using an anti-inflammatory. We do a cortisone injection. We kind of decrease that acute inflammation and then do some physical therapy to strengthen the I keep hitting the wrong button. I got to hit that red one. To strengthen the rotator cuff muscle. If those things fail, then we look at surgical treatment to repair that rotator cuff. Repairing the rotator cuff can be really quite successful. We use a repair of the rotator cuff for the degenerative type is if we've done conservative management and it's failed over a 6-week period of time. If it's an acute type tear that we know that it was due to an accident, then quite often we talk about repairing that type of rotator cuff tear sooner. I always want to see that there's clinical evidence from an MRI of a full thickness type tear. If it's a partial tear, there's a greater chance of healing it conservatively. Usually we want to see full passive motion. So if somebody's locked and they can't raise their arm up, then it's very difficult to do that surgery. But if we can have them take their other arm, raise their arm all the way up, and get that full motion, that is a good indication to have surgery. Also, if people need to do overhead activity, putting dishes away, reaching up, that's an indication to have a surgical treatment. Kind of our poor prognosis for a rotator cuff tear is if there's a long-standing tear. So if somebody knows that they had a tear 4 or 5 years ago and they've kind of thought about getting it repaired and kind of waited and then decide to have it repaired, it's more difficult to repair. And I always tell people that if they have a long-standing repair, if I'm trying to repair it, when I look at that tissue, when I repair something that's acute, a new tear, it's like sewing leather down to the bone again. So you can get a good solid repair. If it's been going on for a while, it's like sewing a piece of tissue paper onto it. And there's just not good tissue to repair. The other thing that happens is with a long-standing tear is that muscle constantly pulls, so it retracts. So if it's retracted, I got to take and pull it all the way back over to reattach it. Sometimes that's very difficult to get that muscle to be pulled back over. Tobacco use, that gives us a poor prognosis for a repair. If there's been no injury, so that's that degenerative type tear. Degenerative type tears have a slightly less good result, so they're a little bit poorer prognosis. And if there's osteoporosis, so a weak bone, it's hard to repair that cuff down to a weak bone. So how do we repair a rotator cuff? Most rotator cuffs are repaired arthroscopically. So that's with a scope. It's making a couple poke holes, one in the front, one in the back, usually a poke hole on the side of the arm. And we go in and take these sutures and put sutures through that rotator cuff and then attach it back down to the bone. By putting this kind of crossed suture in place, it holds that down and creates a footprint for that cuff to be reattached. So this is a little bit more kind of the detail of what we do. We put a couple anchors in the bone. We pass the stitches up through the rotator cuff. And then we start to kind of figure out where we can pull that rotator cuff down to. And we put additional anchors down there that tie these sutures back down into place. And that holds that rotator cuff back down into position. It allows that rotator cuff to heal back down to the bone. Kind of moving on, other than rotator cuff, the other big cause of shoulder pain is the biceps tendon. The biceps tendon runs from the ball. It actually attaches inside the shoulder, attaches inside the socket, and runs down the front of the arm. So pain that comes down the front of the arm can be from the biceps tendon. Quite often that causes weakness with lifting, so with your palm up, trying to lift something up from this position, is from the biceps tendon. Quite often a biceps tendon accompanies other problems of the shoulder also. So when we examine that, we palpate right at the front, right where the biceps attaches. This is the biceps muscle here. We check for the motion, the strength of the biceps, and specifically kind of reproducing pain right at the biceps tendon in the front of the arm. We can also use imaging. So we get x-rays to look at it. We use the MRI to look at the biceps tendon. Our treatment. The treatment is conservative treatment. We can inject into the biceps tendon area with a cortisone, doing physical therapy. Our surgical treatment, we have a couple different choices on what to do surgically. We can do what's called a tenotomy, where we go in, if we see that that tendon is abnormal, we can cut that tendon and we just let that tendon slide down. Kind of the problem with doing that is people get this deformity to their arm. They get this Popeye deformity. They still get the same type of function to their arm, but it does leave a little bit of a deformity. The other treatment is doing a biceps tendonitis, and that is where we take that biceps tendon that's inside the shoulder joint, we cut it, and then we go in the front of the arm and we anchor it into the front of the arm to alleviate the pain. Sometimes this type of deformity, a tenotomy, can occur with a long-standing biceps tendonitis, and it'll just rupture. It just pops on its own. Certainly this is kind of my preference, is to do a tenodesis to it, to catch it before somebody has a rupture, or instead of just cutting it. The other kind of big thing to talk about tonight is arthritis of the shoulder. I kind of divide arthritis of the shoulder into two different parts. And the first part is acromioclavicular arthritis. So that is the arthritis between the collarbone and the acromion. Usually the socket, the ball socket, remains normal. So there's not an arthritis there. When we have this acromioclavicular joint arthritis, that can cause impingement and can cause problems to the rotator cuff. The other type of arthritis to the shoulder is between the ball and the socket, and that's where we've lost that joint space and have more difficulties with motion of the shoulder. So like I said, with acromioclavicular joint arthritis, it can cause impingement of our rotator cuff. AC joint arthritis is real common. I always tell my patients that everybody over 25 probably has some form of AC joint arthritis. They usually have pain with cross arm activity, so that's anything that they got to reach and bring across. Weightlifters, they're extremely common to have AC joint arthritis. Usually I see the most severe arthritis in the weightlifter class of people. My treatment for that is we can do conservative things with observation, anti-inflammatories, cortisone injections, physical therapy, and then at some point talking about surgical treatment. With an arthroscopy, we can go in, there's not a replacement for that joint. Our replacement is taking the end of the clavicle and removing the end of the clavicle. So we make a space that's very narrow, and removing that clavicle makes that space wider to alleviate pain. At the same time, we remove the spur so it doesn't pinch on the rotator cuff muscle any longer. Glenohumeral arthritis. That's that arthritis between the ball and the socket. We look at that. There's some people who have primary arthritis of that joint. That's for really no reason other than, a lot of genetics that play a role in developing arthritis between the ball and the socket. The other group is the rotator cuff arthropathy. You remember me showing the picture with the pencil, and I said there's a hole, and if you keep erasing, you goof the table up underneath. Well, this is what happens when you get that table goofed up underneath. You get arthritis between the ball and the socket. That ball actually rides up high and actually starts wearing the bottom side of the acromion. So that's kind of a severe case of a rotator cuff arthritis. The glenohumeral arthritis can also occur because of the loss of cartilage. The cartilage is what covers the ends of the bone. That's our cushioning property. And when that cushioning wears off is arthritis. So it can happen with people who are over 50. It can occur because of a fracture, because of breaking into the shoulder, or if the shoulder is dislocated. That's what this image is a shoulder that's been dislocated, and the ball actually kind of gets dinged right against the socket. So it produces a little bit of a fracture, produces this indent into the ball. This is a shoulder that's probably prone to developing an arthritis later in life. So what are symptoms of arthritis? The symptoms of arthritis is pain with motion. Most of these people with arthritis of the shoulder have a lot of pain at rest. So even just having their arm rested at their side, it causes them to have pain. They have limited motion. So when we look at our motion, we have flexion, extension, so bringing your arm up overhead, reaching back, reaching out to our side, bringing our arm across our chest. All the motions are limited with arthritis. You just can't get that motion. It actually gets locked or blocked. Quite often they have a noise in the shoulder. So as you move it, you hear a creaking sound or a clicking sound inside the shoulder joint. On examination, we know that on exam, there's the loss of motion. There's tenderness. Quite often it's painful to touch. And the muscles are really weak. Our initial x-rays show an arthritis of the shoulder. Quite often we either expand that with getting a CT scan or getting an MRI of the shoulder. That's to look more closely at the muscle, the rotator cuff, to see if the rotator cuff is intact, if it's still functioning. So treatment for our arthritis is rest, using anti-inflammatories, the physical therapy. Cortisone injections can help with arthritis of the shoulder joint. Heat and ice, whatever feels better. Putting heat to it sometimes helps with improving motion to the shoulder. If it's acutely inflamed, then ice helps to decrease that inflammation. And then we talk about the surgical treatment. The surgical treatment for arthritis is doing a replacement of that shoulder. At the current time, we have two different types of replacements for the shoulder joint. The traditional replacement, which is a socket and a ball that is on a stem. That works really good if there's an intact rotator cuff. For people who have a rotator cuff arthropathy that don't have a functioning rotator cuff, in the past, there was never really a good treatment. We could relieve some of the pain, but never improve anybody's function. And we now have what's called a reverse shoulder arthroplasty. The reverse is where there's a socket, we put a ball, and where there's a ball, we put the socket. And what that does is it pushes the lever arm of the arm out so we can use the deltoid muscle. The deltoid can function better to give an improvement of motion. So when we do a shoulder replacement, all the replacements are kind of the same. We replace the ball in the socket. So surgically, I go in, we cut, we remove that ball. We kind of open up the middle of the bone. We clean out the socket. As we clean out the socket, we can put a new socket in place. There's a stem that goes inside the bone, and that stem can either accept a ball on it or accept a socket for a reverse. When I do a shoulder replacement, I use a computer-guided system. The computer-guided system allows me to get the implant in the most accurate position. Kind of the limiting factor with shoulder replacements in the past have been where to put the socket. And with planning ahead of time for a surgery, I get a CT scan that's actually sent in, and we get kind of a 3D reconstruction of that shoulder, and then I get a specific guide for putting the socket in the best possible position. So, in my closing of shoulder problems is, we want to get a proper diagnosis. We want to know if it's just a bursitis, if it's impingement, if it's a rotator cuff, if it's an arthritis. That way we can kind of direct our treatments. You see an orthopedic surgeon that is versed in taking care of shoulder problems, so we can get a proper diagnosis. Shoulder problems can be treated. We don't have to live with a shoulder that doesn't function. It can be conservative treatment, It can lead to more surgical treatment. I always start with the conservative treatments. And when our conservative treatments fail, then I can have the option of offering the surgery. So hopefully I've helped you improve a little bit of knowledge on what shoulder problems are. I have a staff that can help set up appointments to be seen, and I'll open it up for any questions that you might have tonight.